Okay, we're going to talk about caring. This is chapter 7 in your funds book. There's different principles for giving care. You look at your patient population, you can see all the different puzzle pieces that all fit together here. Theories of nursing. There's different nursing theorists. Now, if you think about a theory, what's a theory? Um, it's anything. It's an idea. It's a thought. It's a belief. I have a theory that the sky turns dark before a storm. I mean, that's a theory, right? So there's different nursing theorists, and these names you will hear over and over and over again throughout your nursing career. So don't just look at these names and go, okay, yeah, whatever, and dump it. You will hear a lot of these names, especially when you get to um, some of your courses at the end of the of this program. You will actually be talking about nursing theory, and then if you decide to go on for your bachelor's in nursing, which hopefully you all will, um, you'll have whole courses just on nursing theory and the theorists, and you'll get to know these ladies very well. I used to cringe at the thought of nursing theory. And crazy enough, I learned to love it and actually absolutely love nursing theory. I used to teach a class just on theory. So there's many different nursing theorists. Honestly, the most important one is not even listed here on your slide. The very first nursing theorist that we have is Florence Nightingale. She's our mother of nursing, right? She is the one that started nursing theory. She's the one that put together, she called them her canons of nursing, where different ideas of having, you know, cl- clean and washing your hands and having ventilation. Not sure how much you know about Florence Nightingale, but she was a socialite from a very wealthy family. She had a passion for nursing, and her family, of course, was very much against it because, she was of the elite, and you didn't want to, you're going to see, naked people, and that's just against, society. But she was adamant, and she went to a Crimean War in Turkey. Um, at that time, men that were either injured or even ill at the time were kept in these barracks, and the barracks were, dark, and kind of the air was musty and dank, and the mortality rate was very, very high. People were just dying left and right. Well, off she goes, takes herself, she was from England, over to Turkey with a group of other uh, women that were helpers helping her, went there to go to make a difference. And it's snowing, it's cold. They refused to let her in because you're a woman. You can't come in here. There's men in here. They're, in all states of undress. Well, because of her connections, because she was um, very elite, um, finally they were like, look, we can't let her freeze to death out there because she refused to leave. So they were worried that they would get in trouble if they let this member of society freeze to death outside. So they finally let her in, and she went through and cleaned. She started opening some windows to get some fresh air. Started washing her hands, and just a matter of that, she dropped the mortality rate. And I don't have the exact figures right in front of me, but in my brain, it seems like it was like close to 50% mortality rate before she got there. And in just doing these things and just walking around and being present and showing these men that she cared, with like a healing touch, the mortality rate dropped. And again, I'm not exact, but I think it was like around 2%. So you think, whatever it was, my figures may be completely off, but it was that drastic. It went from like 50% to 2%. So that made her think and go, wow, what did I just do? So she started writing it down. Guess what? That's a nursing theorist. That is our first nursing theorist, Florence Nightingale. So she's not on here, but she should be. She should be. So these other theorists, Patricia Benner, again, these nursing theorists are big into the caring aspect. That Patricia Benner, that you caring is primary. That you can't be just focused on the medicine and the interventions. You need to show someone that you actually care. You need to give compassion. Madeline Leininger, she is all about culture. She's the one that found that you can't treat everyone from every culture exactly the same. You have to take into consideration their beliefs and their uh, cultural background and incorporate that into their care. Jean Watson, one of my favorite theorists, she is a believer, very holistic, and that basically there can be no curing without caring. And she went into looking all these different, basically like looking into some like research, finding that you the caring and having a caring and healing environment is just as important as the actual medicine aspects of it. Kristen Swanson, again, another theorist into caring, and she she started hers with basically interviewing women that had had like miscarriages. So she started really kind of focusing on that and realizing that there's different caring processes, and um, her caring processes. If you look at page 92 in your textbook, she's got in table 7.2, knowing, being with, doing for, enabling, and maintaining belief. So you might want to read over those. So here's a case study. Mrs. Levine is an 82-year-old patient diagnosed 2 months ago with lymphoma, which is a cancer of the lymph tissue. She's been experiencing weakness and fatigue over the past 4 weeks. She's lost 8 pounds. So she's been relatively independent before her diagnosis. She plays bridge every week with her friends, goes to lunch. Now she has less energy to do the things she enjoys. So now she's your patient. What are some things you're going to think about? What are some things that you are going to talk to her about? What do you think might be some concerns that she has? Is it just about cancer? Is it just about dying? Um, I doubt it. I doubt it. Dying is kind of, in some ways, that's the least of her concerns. Her concerns are more going to be, look, she's been independent. She's been out playing with her, hanging out with her friends, going to lunch, playing bridge. So if she's sick, how's that going to affect her life? How are things going to change? She's independent. She's probably driving to the grocery store. If she's sick, is she still going to be able to do that? Um, what about finances? Chemotherapy is expensive. Is she going to be able to pay her bills? So she's going to have all these thoughts going through her head. It's not going to be just about cancer. All right, so talking again about the theory, talking about caring is highly relational. Yeah, relational. These again, all of the nursing caring theories, the theorists that we talked about, they all have kind of a common theme. You need to understand the illness. You need to understand also the patient's their reaction to their illness, how their thoughts are. All right, so next part of the case study. Miss Levine's son, Jim, lives only a few miles away, and he's a consistent resource when she needs transportation to the physician or trips to the grocery store. She will begin a research protocol for chemotherapy treatments this week at the oncology clinic. Okay, well that's good. We now know some social background. She has a son that's going to be able to help her. So that's a good piece of information for us to remember. Um, how do you think Jim is thinking about all this? The patient is not necessarily our only patient. You've got the family to think about as well. Um, Jim is just is your patient as well. He has got a lot of concerns. He's worried about his mother. He's worried about his mother's health. He's going to be worrying about himself. If she's sick, she's going to rely on him more. Who knows? Maybe he's still working full time. Maybe he has family of his own, and now he's going to have to figure out how to take care of his mother as well. So it's called caregiver strain. So we'll talk more about that later. So with the patients, you have to look at their perspective. Um, if think about yourself as a patient, if you had a caregiver that was just very aloof and just kind of came in and did what they have to do, and they don't really talk, they don't really make eye contact, they don't introduce themselves. That's a big hot button of mine. Introduce yourself. Um, what are they going to think about you? I have an example of that. Took my daughter for a consult for have her wisdom teeth removed. The doctor came in, didn't introduce himself. He's rushed. He's in a hurry. He's walking really fast. He's talking super fast, and he just zips right through it. And I was like, okay, all right, just let me know. Zipped right out. I mean, it was like a tornado. And he may be the most awesome oral surgeon in the world, but I really don't think I'm going to use him because I didn't like him. I mean, he was nice, he was pleasant, but it was all business. Zipped in and zipped out. And, I would like somebody to act like they give a darn. And that's exactly what this is about. Your ethic of care, the caring is basically an interaction of mutual respect and trust. Ethics are right and wrong behavior, right? You'll get into that even more in other classes near the end. Really, you'll talk a lot about ethics and laws and the difference. Laws are things you have to do. Ethics are the things you should do. Ethical behavior is doing the right thing when nobody's looking. All right, continuing on. So Sue is a nurse that's worked in the oncology clinic for more than 10 years. She enters the exam room where Miss Levine is waiting, introduces herself, and sits down next to her patient. There we go, right there. She introduced herself. She says, I am here to understand your story. I want to listen and learn how I can best help you. She uses eye contact. She leans toward Miss Levine. Miss Levine nods, smiles, and begins her story. What, what do you think about that? If you had a nurse come in and act like that, would you get that warm fuzzy feeling? Yeah, you should. She's actually acting like she cares. Here I'm here to understand. I want to listen to your story. Um, you will grow in your ability to care and develop caring behaviors. This is it is a skill. It is a skill. It's a skill especially when people are not terribly receptive. When people are ill or they're hurting, they've been injured, they're a lot of times they're not going to be in their best behaviors, and that's that's no excuse for us as nurses to not be on our best behavior. Let me say that again. People are sick, they're in pain, they're not going to be on their best behavior. They're going to be grumpy, they're going to be cranky, they're going to be not so nice. That does not give the nurse an excuse to be the same way. It is expected for that patient to not be feeling well and to be cranky. It is absolutely unacceptable for us as the caregiver to be that way. Ooh, I can't back up. I don't know how to back up. But anyway, there was another thing here. You should treat your colleagues with respect and caring as well. That's something that I see a lot in nursing school, and I'm not just talking about here because I've worked at several nursing schools, but um, y'all are here to be nurses and to care and should be empathetic and um, just caring individuals, and you usually wonderful and great with patients. But to your classmates, you know, I see sometimes some nasty behaviors, and it's like, are you sure you want to be a nurse? Because that's not a nurse behavior. Um, so think about that. Think about that even with your colleagues, with your peers, with your classmates, when you're working with your coworkers. You don't always know what's going on in somebody's life. Everybody has a story, and you need to think beyond just the face value. You need to understand and think about maybe what's causing certain behaviors. Maybe, okay, well, yeah, she yelled at me or she was disrespectful to me. Maybe she didn't mean to be. Maybe she's got something really heavy weighing on her, and it came out that way, but it wasn't really that way intended to be. It's just there's just other things going on, and it's not about you. That's what I tell my kids. It's not always about you. Sometimes there's things going on in the background. Open your mind and think about that. Providing presence. What does that mean? What does providing presence mean to you? So, they talk about that even being present. People with their cell phones nowadays um, got their nose in their phone, and um, they're not present. You go out to dinner with your family and you got your nose in a phone. You're not having dinner with your family, you're having dinner with your phone. The same thing is with patients. We've got, our computers, we're doing charting. Charting is secondary. You need to be eye contact with that patient, and you need to be present. You need to be um, being there. You need to be with them when you're with them. Continuing on with our case study, so Miss Levine explains, I've had a good life. I just don't know what's going to happen. Doctor tells me cancer is serious. I worry about what is going to happen to me and how it will affect my son Jim. I don't want to become a burden to him. See, there, it's not about dying. Now she's worrying about becoming a burden to her son. Sue, the nurse, in a calm, soothing voice. Miss Levine, your concerns are very normal. It is important for you to remain as independent as possible. Let's talk about how we can do that. Immediately, Miss Levine's worrying about not being independent, and Sue very calmly says, "I understand. I know where you're coming from. Let's talk about how we can help ensure that happens." Don't you know Miss Levine is immediately put at ease? Don't you know that she just had some anxiety just leave her body? She's still going to be worried, but it's Sue's response just helped tremendously. Sue could have been typing on her computer and making notes and just, uh-huh, yeah. Well, did that help Miss Levine any? No. It's probably going to cause her more anxiety because Sue obviously doesn't give a crap. Touch, therapeutic touch. Touch provides comfort. It creates a connection. This is, when somebody's upset or hurting, where you pat them on the back or you touch their arm to let them know you're there. It's establishing that connection. Now, therapeutic touch. Therapeutic touch is very important. However, pay attention to the cues from your patient because some people don't like to be touched. And you go to touch somebody, pat their arm or pat their back, and they cringe or they pull away, then then offer that, um, you know, let them know you care, but without the touching. Maybe it's more of the eye contact and just the voice, but don't touch them because some people, they may have a history of abuse. It may be cultural. Some cultures they don't like to be touched. I made the mistake as a nursing student, a man that was a quadriplegic, and I felt really bad for him, and I reached over and kind of, I rubbed his, kind of his head because I knew he could feel my touch there because he was paralyzed, and he immediately jerked away and gave me a nasty look, and I was like, honestly, it hurt my feelings. I was kind of like, what did I do? What did I do? And um, found out that it was his particular culture. Then, how dare I touch him? So, and I struggled with that. I kind of struggled with that as a nursing student, going, okay, so not everybody likes to be touched. I obviously offended him by touching him. So does that mean I need to quit touching people? Or do I still touch them? And I realized that 95% of the population appreciates that therapeutic touch, and a very small percentage don't like to be touched. And so I went with, I'm going to still offer that therapeutic touch. And if I see any cues or any signs that they don't like it, they cringe, they pull away, then I'll just know not to touch them. But I am always going to offer that because I would rather give that therapeutic touch than not when somebody does want it. All right, quick quiz. Woo! Female patient just found a large lump in her breast. Physician needs to perform a breast biopsy. The nurse helps the patient into the proper position and offers support during the biopsy. The nurse is demonstrating what? Is she enabling, comforting, a sense of presence, or maintaining belief? What y'all think? All right, it's a sense of presence. The nurse is right there. She's helping support her. She's helping move her into position. She's being present. She's there for her. She is giving her that support. All right, so back to Miss Levine again. So she has consistently relied on her son Jim to provide caregiving support by assisting with transportation and being a day-to-day resource. Jim brings his mother to the outpatient oncology clinic for her first chemotherapy infusion. Total treatment will last approximately 5 hours. Sue invites Jim to sit in the treatment area with his mother. Okay, so that was nice of Sue, right? Because I'm sure he's just as confused and anxious and scared as his mom. And so what? Okay, thank you. We'll take her on back and do her treatment. You go do whatever. I mean, that's not going to help him any. Remember, he's also part of he's your patient as well. You need to be thinking about him. But he's treated warmly and he's invited back. Come, you can come back, sit back here with your mom. Come back here. You can sit with her. Um, Maybe sit and watch a movie together. I mean, that's going to comfort them both. That's going to make them both feel better. It's going to make Miss Levine feel better because she's going to have her son there next to her. It's going to make him feel better because it won't be unknown. He won't be like, oh, what are they doing to my mom back there? Is she in pain? Is she okay? He'll be there with her. Listening. Wow, this is a big one. I've talked about communication a lot in other classes and talked about different forms of communication. And, people are always big on, body language or written communication and verbal communication. People always tend to forget about listening. Listening, that's one half of communication. There's no point communicating if there's nobody listening, right? Listening is a skill. Listening is tough. Yeah, we listen to people, but do we really listen to people? True listening means knowing, responding to what matters. Listening effectively, that means you need to be quiet and you need to keep an open mind. Now, active listening. How many times do people talk to you and they're telling you a story and your mind is um, going through where you're thinking of your response already? And you're already thinking about what you're going to say to what they just said, or you even interrupt them to say what you want to say. That's not active listening. To active listen means you are engaged and you're paying attention to what someone is saying without thinking of a response. You are um, you are focused in on hearing what they say. This is huge. This is huge. I have one day that I one day a week that I go to a um, primary care doctor's office and see patients as a nurse practitioner student. And my preceptor, God love her to death, but she's not very good at listening. She's so busy typing in her computer or checking their computer or looking at labs, and she misses things because I'm sitting there usually just observing. Um, and there's some very important pieces of information that she completely misses, and it has affected the treatment. I've had to kind of interrupt, when she's off on a roll about what kind of treatment or what kind of labs or diagnostics that um, because I sat and actually listened to the patient, I know that she's off on the wrong track, and I've had to interject. Um, just and it's just something very quick. Patient was talking about her head itching really bad, and um, she's done everything, and it keeps itches, and she scratches, and she's having hair loss because of it. And immediately my preceptor's off onto this whole, okay, well, let's look at something to help with itching, something for like histamine. And so as she's typing away and kind of like, as she's typing, now this is the preceptor, patient says, yeah, well, they said I had a dermatologist a while back said I had psoriasis, but blah, 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 and keeps talking. And it was just this one little thing, psoriasis, and then she went off and was talking about something else. My preceptor completely missed that word to the point where I finally, even the patient was still just going on about something. I kind of stopped her and went, whoa, 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 wait a minute. I said, did you say you have psoriasis? And she's like, yes. And then when I said that, my preceptor looked up and went, wait, what? So you got to listen. You got to listen. Knowing the patient, understanding what's important to them. Sometimes what's important to you isn't necessarily what their main focus is. So understand where they're coming from. Understand them. Um, Different things, factors of knowing. Interesting, continuity of care. Do y'all know what that means? Continuity of care. So think about like in a hospital. It's a charge nurse works really hard to keep the same nurse with the same patient assignments throughout. Like if they work 3 days in a row, all 3 days they'll have the same patients. That's continuity of care because as you're with that patient for the 3 days of your 3 day shift, you get to know them. You know them more and more. You understand them, and they're more comfortable because they have the same nurse. They know you. Continuity of care is important. All right. Continuing on with our case study. So outside the treatment room, Jim says, how will my mother respond to this chemotherapy? What should we be expecting? Based on Swanson's theory of caring, what might be an appropriate response of Sue's part in maintaining belief? So, one thing I want to think about is Jim. Jim's worried about his mom. He's wanting to know how she's going to respond and what should we be expecting. This is not just all about his mom. This is all about him because he's now got to think, oh, she's going to need, a lot of support. She's not going to be able to, let's just say his mother doesn't respond well to the chemotherapy treatment very well, and she needs somebody to help get her meals. And if he's still working, now he's got to start thinking about how he's going to be able to help care for his mother. So again, it's not all about the patient. You got to think further than that. Um, Maintaining belief. This talks about maintaining belief. Maintaining belief is basically sustaining faith in another's capacity to get through an event. So some things that for maintaining belief, this is maintaining a hope-filled attitude but offering realistic optimism. You don't want to ever say, it'll be fine, she'll be fine, because guess what? You don't know that. You don't ever say that. What you have to do is be very realistic and um, set the stage appropriately. Spiritual health, that's the balance between life values, goals, and belief systems. Um, and also think about, the patient's spirituality. I know in the hospital, I've always worked like at Baptist downtown and Baptist South, and some of the things that we do is we ask, would you like the chaplain to come visit? And so we do encourage that. Um, Relieving symptoms and suffering. This is always providing necessary comfort and support measures. This is again not just to the patient but also to the family. This is Jim is sitting there in the treatment room with his mom. Well, let's say it's very cold in there, so we're probably going to offer Mrs. Levine a warm blanket because she's having the chemotherapy. But let's not forget about Jim. He's sitting in there too. He may be cold as well. Offer him a warm blanket. Offer them, some some water, or something to drink, if it's allowed for the patient, but of course the family. Listen, Jim may be really stressed and nervous and worried, and he may need to talk. So again, you want to listen. I In the hospital, you're very busy. You have, depending on what kind of floor you work on, 4, 5, 6 or more patients. You're hopping. You're busy. But to go into a room and just perform a task, I have to go into this room and give this patient their medication. And you want to rush in and you want to give them their medication and you want to move on and go to the next room and give their medication. Well, the patient wants to ask questions. They're worried. They're nervous. They have concerns. Um, you can either be that nurse that goes in and is very rushed and very hurried and gives them their medication and is very abrupt and short and cut them off, which I see all the time. And guys, I'm going to say this now. I hate saying this, but I see it a lot with the younger nurses, new nurses, because they're so focused on the task. I just got to check off that little box that says I have to give meds at 9 a.m. in the morning. So they're so laser focused on that task that they forget there's a human being on the other side of it. You have got to slow down and stop and talk to this patient and give that patient a feeling that you've got to let them know. You've got to listen to them. You have to address their concerns. You have to take the time. That is your job. That is part of it. And it's part of being just a decent human being as well. You know what? Your tasks will wait. If a patient needs you, then a patient needs you. And if you're going to be 5 minutes late doing something to check off that little box, well, then you're 5 minutes late. I promise you, you will not get in trouble. I promise you, you will not get in trouble. The important thing is to care for that patient. This talks about family. I think I already harped on that enough, didn't I? All right. 3 hours into the infusion, Mrs. Levine asks Sue for a glass of water and begins to talk about her pet cat and her desire to return home and be able to visit with one of her bridge partners tomorrow. Sue has another patient down the hall who has an infusion that's been underway for about an hour. What should Sue do to show her caring for Miss Levine? So again, we kind of talked about that. You're not going to have just one patient. You've got to be able to balance, and you have to balance in a way that you are not task oriented, but you are patient oriented. You give that patient all of you are present, then you move on to the next patient and then you're present with that patient. I promise you it it's better for you, it's better for them. Another quiz. When a nurse enters a patient's room and says good morning before starting care, the nurse combines nursing tasks and conversation. An important aspect of care for the nurse to remember is the need to what? Establish a relationship, gather assessment data, treat discomforts quickly, or assess the patient's emotional needs. What do y'all think? Good morning. Now I'm going to give you your medicine. Why do we say good morning? Why don't we just walk in and here's your medicine? We're going to assess the patient's emotional needs, right? We're going to see how they are. Are they going to be like, what's good about it? Well, then it gives you a clue something's going on with this patient. Oh, well, are you in pain? Is everything okay? No, I've had to go to the bathroom for 30 minutes. Nobody will come in here and take me to the bathroom. Okay. Or, um, no, I'm not okay. I'm in the hospital. What do you think? So it's a good opportunity to get an understanding of that patient. Not only that, but it is an assessment because this is my neuro nurse here. You walk in and say good morning, and you've had this patient yesterday, and the patient was very talkative and would say good morning. And today you say good morning, and they go rah, 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 rah. Well, that's a problem. We got an issue here. Did the patient just experience another, a stroke, or so it is assessing their emotional needs, it is, relationship because you're coming in being, friendly, cheering, caring. It's also an assessment. So it's kind of everything here. All right, challenges of caring. Ooh. So I love this task oriented. That again is like I said, I got a whole list of tasks I gotta get done today. My job is going through getting my tasks done. Yeah, guess what? You'll get your job done, but you're missing the whole other side of that, and that's the patient side. The demands of the institution. That's the hospital saying, oh, yeah, we'll give you 8 patients, and you got to go in and treat them all like they're royalty and make sure that all their needs are met, and you have to do it. And you have to chart all these everything. Um, yeah, that's where there's problems. That's when the institution is not setting you up for success. Um, Nurse patient ratios are a huge thing with nurses right now because we as nurses have expectations of patient care, and when institutions try to give us too many patients, we're unable to do that. And this is what causes dissatisfaction with the job because you're not able to perform as you feel like as you should. Time constraints again. Yes, you've got to keep an eye on your watch. You've got to give patient care. It's it is a challenge. If any of y'all ever been a waitress, it's you kind of know how that is. It's like you got to give that person all your attention and your focus, but then you got to kind of keep an eye on your watch because you may have time-sensitive labs. You may have this patient may has emotional needs that need to be addressed. They may be crying. They may have just found out that they've got terminal cancer, so you're there giving them support. But you also have your patient next door that needs a Venco level drawn at 9 a.m. sharp, and it's now 8:59, and you've got a crying patient. This is stressful. This is tough, but it can be done, and it can be done. You don't leave your crying patient. You would probably would reach out to your charge nurse and say, hey, can you help me here? Can you go draw that Venco, that lab for me? Um, Reliance on technology. We rely on our computers for everything. You've got electronic medication records, and you rely on that EMR, electronic medication record, EMR, um, to see what you need to do, what medicines you need to give, and all of a sudden the computers go down. Oh, crud. Now what? Well, don't 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 stress over that because I promise you hospitals have a backup plan. But it does make it challenging. Healthcare must become more holistic and humanistic. It's got to be. You have to think about, as a nurse, we focus on mind, body, and spirit. We are holistic. We look at the whole body, mind, body, and spirit. Physicians, typically, they are concerned with the medical aspect. They look at the medicine. They look at the body and what abnormality is here, what disorder, what disease, what kind of intervention, surgical, medical, um, or pharmaceutical, can I do to put that body back to as normal as possible? They're not as concerned about the whole body, the spirit. Um, so again, as nurses, we are holistic. We look at the whole body. Alrighty, that was enough of this chapter. If you have any questions, please reach out to me. Thank you.